Thank you. My name is Christina Chambers, and I'm a professor in the Department of Pediatrics at UC San Diego and an investigator with the Imprint Center of Excellence at UC San Diego. And I'm going to be talking today about a clinical project that's part of our Center of Excellence focused on optimization of antibiotics in mothers and their breastfed infants using microbiomic and metabolomic analyses. So the clinical project I'll be covering today is focused on examining the pharmacokinetics of commonly used antibiotics in human milk. And we're using existing infrastructure at UC San Diego under the Human Milk Research Biorepository that we established here about a decade ago, where we are enrolling 500 women approximately who are breastfeeding infants less than 4 months of age and collecting samples from those women as part of our baseline collection. And then following those women enrolled at baseline to identify 40 who have initiated antibiotic treatment sometime in the course of breastfeeding, and at the same time to identify 40 matched controls who have not initiated antibiotics but are at the same age and time in breastfeeding as those who were treated, and to collect the same set of samples serially over the course of that antibiotic treatment time period. And then our goal is to perform pharmacometric analyses using our pharmacometric and analytic chemistry core through our Imprint hub to evaluate PK, and secondly, to examine the relationship between antibiotic treatment and mother-infant physiology using our milk analytics core to examine human milk oligosaccharide profiles in the treated and untreated group, and our data core to examine the metabolome and microbiome differences between these groups as well. And then our last goal in this clinical project is to evaluate outcomes in breastfed infants whose mothers were treated versus those who were not, using medical records. And from medical records at about 1 year of age, we're abstracting growth, weight, length, and head circumference percentiles, and evidence of infections, both serious and non-serious, and hospitalizations up to 1 year of age following the treatment period. And from direct assessment, we're capturing neurodevelopmental screening data from the parent or primary caregiver. So as I mentioned, the basis for this project is the UCSD Human Milk Research Biorepository, where we have in place an infrastructure to recruit individuals who are breastfeeding and to collect a wide variety of metadata as well as the samples. So the sample collection schema for the clinical project is shown on this slide. I'm focused on the first 2 rows, which are breastfeeding treated with antibiotics and breastfeeding not treated with antibiotics. At baseline, everyone gets the same sample collection: fecal skin, breast milk, and environmental samples. And then once a mother's enrolled in the follow-on study for antibiotic treatment and her matched control is identified, we collect the same set of samples at the start of the antibiotic treatment period, mid-treatment, which of course varies by drug, and then at the end of the antibiotic treatment period, both in the treated and the comparison group. I'm going to give some preliminary project results here. We have completed enrollment of the initial baseline participants and the 40 treated, 40 untreated in the follow-on study. We identified about 42% who were treated with amoxicillin, and then a variety of other antibiotics as shown on this slide. And near half were treated for upper respiratory infections among those treated with antibiotics. We do routinely capture information on co-exposure, which of course will be important in terms of doing some of the analyses for HMOs and for our metabolome and microbiome. And you can see here in the subset of antibiotic treated, the variety of supplements, recreational substances, over-the-counter and prescription medications that were co-exposures in this sample. Now for the outcomes, these are not the final outcomes. We have received medical records from a subset of about 61 participants of the 80 still awaiting medical records for the remainder. But in this preliminary analysis on infant growth, the red box plot figure shows the treated and the blue the untreated, and you can see the means are slightly higher for growth percentiles on length, head circumference, and weight for the treated group versus the non-treated group, but there are no significant differences at this point on any of those measures at about 1 year of age after adjustment for birth size. In terms of developmental screening, we have 2 time points at which the mothers can complete these questionnaires, and we've divided them into 2 age groups, 12 to 22 months, and then 23 months to 30 months. To date, a subset of 61 children were evaluated at least once, 61 in the 12 to 22 month period. The domains that are evaluated on this screening include communication, gross motor, fine motor, problem solving, and personal social. So in this age range, looking at those who scored in the abnormal range versus those who didn't, we see no significant differences between the groups at 12 to 22 months. And with a smaller subset of those who've completed the questionnaire, again at 24 to 33 months, 26, I believe, are in this sample. We see no significant differences, but again, the sample is small, and we continue to collect data at the second time point. And then finally, the results with respect to serious infections or hospitalizations. We have a subset here of about 55 for which we have the medical records abstracted for infections and hospitalizations, 27 in the exposed and 28 in the unexposed. And as you can see here, we've had no confirmed serious infections or hospitalizations in the exposed group in that follow-up period up to 1 year of age. We've had 8 out of 28 in the unexposed group that had serious infections or hospitalizations. So a significant difference at this time point, but continuing to collect the additional data from medical records for the remaining about 25 or so. So our next steps, our samples are being analyzed as we speak for pharmacokinetics for the human milk oligosaccharide profiles in the 2 groups, and by our data core for metabolome and microbiome between the 2 groups. In particular, metabolome and microbiome, looking at the multiple types of samples that were collected from each individual mother and child. And then we'll be finalizing collection of the outcome data on growth, neurodevelopmental screening, and infections for the full data set, and hopefully have that to present within the next 6 months or so. So thank you for your attention. I appreciate it.